In this video, we'll cover the herpes simplex virus. So, first of all, what it does is it causes a recurrent mucocutaneous infection. Now, it is basically HSV1 and HSV2. So, the first one affects the mucous membrane of head and neck, and the second one affects the mucous membrane of Genital area. All right. Now, it is basically a common virus which causes non-specific illness during childhood. Hence, many people have serum antibodies against the organism. Now, it can occur in immunocompromised patients and it can be very fatal in them. Alright, now let's talk about the pathogenesis. Now, the portal of entry is through mouth or skin. Then what we see is it enters into the sensory and the autonomic neurons. It establishes a latent infection, and then there occurs an episode of reactivation, and then we see the manifestations. All right. Now, what are the clinical features of herpes simplex? Also, neonates can also uh, be affected. This is from an infected mother. So, in clinical features, we divide them into two categories. One is the primary and one is the recurrent. Okay. Now, in primary, first of all, we have ulcerative gingival stomatitis and esophagitis, then balanitis, herpetic whitlow in medical personnels. It basically happens like, suppose this is the hand, it occurs over here. All right. So then vulvovaginitis, keratoconjunctivitis, then encephalitis. All right. Now, in recurrent, we have herpes labialis, radiculomyopathy, and recurrent meningitis. Because all this question looks very empty without a diagram, so you can just draw the basic structure of herpes simplex virus. Please do not confuse it with herpes zoster. They both are different and they cause different things. So this is the nucleocapsid. This is the viral tegument. Then this is the envelope. This is the envelope protein. All right. Now, the primary attack, it can be associated with fever, lymphadenopathy. Now, it also affects the CNS. That is quite obvious. Now, in the recurrence part, why does recurrence occur? Now, either it can occur due to the menstruation, mechanical trauma, mental illness, oral lesions, UV exposure, psychological states, also immunosuppression. All right. Now the prodromally, what happens is there occurs prodromal hyperesthesia followed by vesiculation, pustulation, and crusting. Now let's talk about the complications. Now for the complications, you can remember it by antihypertensive BP decrease. Okay, so by H we have herpes labialis. Now herpes labialis, uh, wait, first we'll talk about herpes keratitis. Now what happens is, in this it basically causes the dendritic ulcer, which is visible on slit lamp examination, due to which there is corneal scarring, permanent visual impairment. Then by T we have temporal lobe epilepsy. By B we have Bell's palsy. By P we have pneumonitis. By another P we have primary Herpes simplex virus 2, which causes meningitis. Now, there is one thing that I think you must be remembering. The CSF changes in viral meningitis or aseptic meningitis. Do you remember that in normally when we see meningitis, we see that the glucose level decreases and the protein level increases, and whereas in the viral one, what we see is the glucose level, it remains normal and the protein level increases. This is a very important difference that you must remember, and it is usually when a most commonly asked question in MCQs. So yeah, this is the difference between viral meningitis and the tubercular meningitis, or even the general meningitis, right? So then after P, we have covered P. Now we will write about D. So disseminated cutaneous lesion in people who have skin disease called eczema. Now for the investigation, first of all, the virus, it can be cultured. Then we usually use the Giemsa right stain, and also we can use the Papniculo staining, and we see that it gives out giant cells and intranuclear inclusions. Then we see that there are rising antibody titers. Then we can also do the PCR, direct immunofluorescence test. All right, even in cases of herpes simplex virus encephalitis, we will use the CSF for diagnosis. Now let's talk about the treatment. So first of all, herpes labialis. Now this is usually which occurs during the recurrent phase. So this is treated by oral acyclovir 200 milligram 5 times a day. All right, then we can also then we will talk about the recurrent genital, in this acyclovir, but in the dose of 800 milligrams for 2 days TID. Also we will give valcyclovir 500 milligrams BID for 3 days. Now in patients who have proctitis or bursitis, uh, and they are HIV positive, we usually give the acyclovir in high doses. So in high doses, what I mean is in 4 to 5 grams. All right, now in neonatal diseases of herpes simplex, we give acyclovir, either oral or intravenous, based on the condition of the patient. We usually give 5 to 10 milligrams per kg every 8 hours. So this covers the herpes simplex. I hope I made it easier for you to understand, and please do not confuse it with herpes zoster. They both are different. So yeah, so this completes the video. Thanks for watching.